Ladies and gentlemen, we now begin our second session on the program. The theme of this session is economic and social perspectives around communicable and non-communicable diseases. And the chair is Dr. Karen Seeley. So I'm going to hand over now to Dr. Seeley.
Thank you. Thank you. I am planning to, in fact, chair from here. So that we'll make it easy and I won't waste the time that I'll have to walk. I'm also going to cut short the introductions because we've lost a little time, and I've asked the panelists to see how they can, in fact, put their 15 minutes, which they originally had, into 10 to 12 minutes. The important thing that I've asked the panelists to do is, in fact, to then focus on the provocative concepts or the provocative findings that they wish to present this afternoon so that we can then have a really vibrant discussion at the end. Our first panelist is Beharry from the Health Economics Unit. Vyjanti has a bachelor's and master's in science and an MPhil in economics. She has worked at the Health Economics Unit since 2002, soon after she obtained her master's. And she's particularly interested in health financing and costing of health services. She's going to present a paper which looks at different models and tries to look at to what extent people's risky sexual behavior can be explained by the costing or by to what extent you can use costing to kind of anticipate what risky behavior would lead to. So cost resistance is a new concept for me, and I'm looking forward to this paper. Vyjanti, it's all yours.
Hi, good afternoon, everyone. This presentation is based on a paper that actually tried to apply the economic theory of rational behavior, rational choice theory, to how people behave with respect to risky sexual behavior and, by extension, HIV infection. It also looked at some of the more traditional behavioral models and how they sought to explain and predict behavior and behavior change. And we also suggest some possible policy implications of our findings. Okay, so I think in keeping with the theme of the whole conference, I would like to start with a quote from Professor Theodore. And essentially what we would like to take away from this slide is the focus really on the human resource aspect of HIV and AIDS and how it impacts on this very essential pillar of any economic system, because we know that as long as this essential pillar is affected, there's a domino effect really with, that can impact on other pillars of our economy, savings, investment, our production function, etc. So overview, we're just going to look at we can't speak about HIV and AIDS without looking at some of the figures presently, the relationship between the behavioral theories, what is the concept of cost resistance, and some of the policy implications. So HIV and AIDS is still a prominent feature of our, of the global and of the regional landscape. And this is UNAIDS, this data came from the UNAIDS. In 2014, 36.9 million. It should also just be noted that new infections have been decreasing over the years, but still to note is that there are still new infections happening. And of course, 66% still happen, of the new infections still happen in the sub-Saharan African region. HIV prevalence rates still have around 1 to 2%, and there were about 13,000 new infections in the region, which is a decrease by 50% between 2000 and 2015. So there have been positive trends in respect to HIV infections. Just shows that some of the prevalence of different regions in the world, and we see that even though prevalence rates have been decreasing in the Caribbean, it's still second to sub-Saharan Africa. And these slides, we could just go through them quickly. It just shows that in selected Caribbean countries, in most Caribbean countries, the incidence has been decreasing over time since like around 2000 in most of the countries. And it also should be noted that around this time is when the countries actually made concerted efforts towards implementing strategic plans to deal with the issue of HIV and AIDS from this time onwards, and it is when also the Declaration of Commitment to the Pan-Caribbean Partnership Against HIV and AIDS was issued. So that really was a pivotal step in responding to the epidemic in the region. Currently, most countries are on the second round, and maybe a few on the third in terms of implementing response programs. And response programs are now multi-sectoral in nature, meaning that they try to incorporate HIV response in every sector, every element of the economy, the country. And also they are targeted in initiatives for groups across the board. Okay, so the main behavioral models that we would look at, mainly four we would look at: the theory of reasoned action, the health belief model, the AIDS risk reduction model, and the transtheoretical model of change. The theory of reasoned action, this is the four main elements being beliefs, attitudes, intentions, and behaviors, with intentions being viewed as the most important determinant. And intentions or behaviors, the thing that we need to know is that these intentions or behaviors are subjective evaluations by individuals. So that interventions that cannot be generic or general in nature. It needs to be, to a certain extent, targeted to the individual so that it impacts on how they perceive their risk and their, the benefits of responding. Okay, and one of the things with the, this model also is that when interventions are crafted, it needs to be defined in specific terms. So it cannot be too general. You need to define what behavior you're going to change, who is the target audience, what is the expected outcome. Okay, so the second model is the health belief model, and this model was, the purpose of this model really was to explain why populations' participation in prevention programs, there's a poor response to that. That was the initial purpose of this theory, and they found that to a large extent it was based on the perceived a person's susceptibility to the disease and their perceived benefit of changing that behavior. And studies conducted using this model, behavioral studies, found that there's a negative relationship between how a person perceives their risk and their risky behavior. There's a negative one, meaning that as your perception of risk increases, as you believe that you are more prone to be infected with HIV, your incidence of risky sexual behavior decreases, and this was found to be among females and not males, pointing to the fact that interventions maybe need to be gender sensitive. Okay, what is important in this slide is that even after the individual analyzes or measures their risk and the benefit of responding, they also need to have cues to action, meaning that they need to always have positive reinforcement. So there's a group dynamic, interpersonal relationships that continues to motivate them to change their behavior. The other model is the Transtheoretical model of behavior change, and this introduces the concepts of pre-contemplation, contemplation, preparation, action, and maintenance. Action and maintenance being the actual change in behavior. In the contemplation stage, that is when people are actually thinking about whether or not they should change behavior. There's this cost-benefit analysis. So throughout all of the theories, we see that persons are always assessing what are the costs of changing behavior, what is the benefit of changing that behavior. And it was found from an analysis of 12 studies that the benefits of changing behavior must be at least twice as much as the cons of not changing. So they put a high value on current behavior as opposed to changing that particular behavior. Okay, so just this, the previous slide shows you all of the different steps a person goes through in this model when deciding to change behavior. And this is just the different steps grouped into the different phases of behavior change. Now, this model, the age risk reduction model, was developed for HIV in particular. So it is based on the hypothesis that behavior change is a three-stage process. First, you have to recognize your behavior as being high risk. You have to make a commitment to reduce that risk. And third, you have to take action that reduces that risk. One of the important facts to note with this particular model is the role that environment, culture, social norms have to play in terms of how it impacts on an individual's assessment of whether or not they should change their behavior. So even though they would have all of the general knowledge and education, they would be educated about what the modes of transmission, prevention, activities, what they should do. Peer pressure, group dynamics play an important part in determining whether or not persons would behave a certain way. Okay, so in summarizing the main points from the behavioral model, one of the critiques has been that the focus really is on individuals, individual assessment of their risk, individuals' perception of what the benefits of changing behavior would be. And I think more focus needs to be on how groups, interpersonal relationships, culture, your community, all of that, how that impacts on the decision space of the individual. So how does that impact on how a person behaves in addition to their own assessment of their situation? And of course, the key concept that cuts across all of these is the subjective assessments of a person's risk. So our paper then attempts to apply the economic theory, rational choice theory, to try to predict or to try to explain, how persons choose one behavior over another. And everybody make choices that maximize their own utility or satisfaction. And in economics, we coined this, there's a utility function that each of us operate by. And that utility function measures our levels of satisfaction. It tells us how we make choices between certain goods. What combinations of goods will yield us the maximum amount of satisfaction. So for instance, if you have 2 goods to choose from, this utility function will tell us what combination of goods will give you a certain level of satisfaction. Of course, this is in isolation of our limits, our constraints. And with normal goods and services, the constraint is usually a budget. So yes, you would like to choose unlimited amount of either good, but of course we are constrained by our budgets. With respect to behavior choices, we propose that the limiting choice is a behavior constraint, and regardless of what our motives are for certain behavior, so some of us might be thrill seekers, risk takers, and that will influence the types of goods, the types of behaviors we engage in. But regardless of that, our behavior is constrained by certain factors such as legislation, social norms, culture, and this really puts the budget constraint line being behavioral constraint in this context. So the concept of cost resistance then, it is the refusal to discard the utility function to which one has been accustomed. So that the cost really, if the cost of risky behavior is HIV infection, cost resistance is the inability to view that as a cost. So persons who are engaging in risky sexual behavior may not see HIV infection as a cost, but they might actually see not engaging in that particular behavior as the cost. So that the not engaging in that behavior will not be a benefit to them then of not getting HIV infected. So that really is the underlying premise behind what is cost resistance. So some of the policy implications. An individual may reduce his or her number of risky sexual activities when the prevalence rate for HIV increases. And we are saying that, for instance, if a national prevalence rate of 2% may mean very little to someone who they may think that, okay, well, that's just 2% of the entire population, that doesn't affect me. But when the rate is localized or decentralized to your own group or to your own community, it becomes more real to you. So what we are saying is that, you know, prevention activities, promotion needs to probably be more community focused and or group based on the groups. And this has been happening to some extent in response programs where you have interventions targeted towards vulnerable groups, and you also have prevalence rates being published for these particular groups. So it makes it more real to persons in that group. And we also introduce the concept of libertarian paternalism, which is really changing the characteristic of the choices available to people. So we are not limiting their choices, but we are just changing the characteristics of the choice. So, and we do this to some extent by the ban on smoking in public places, etc. So this is one option that we could look into. And we heard this morning the discussions leading towards the regulation of the food industries and that sort of interventions. And also, in terms of socio-economic policy, we need to find a way to quantify the future benefits and make the present value of the future benefits more visible so that persons will not see not engaging in a particular behavior as a cost really, but they should see it as a benefit. And this recommendations, well, amounts of bribing, if you would put it that way. But, you know, it's something that we could look into. Okay, so, of course, all of these policies needs further research in order to determine really if what is the feasibility of all of these policy implications, because of course some of it seems very difficult to implement, some may be costly to implement. And so more research really into the connection and the correlations between behavior and, let's say, alcohol consumption may be needed in order to guide and drive some of these policies. And I would like just conclude with a statement from Prof. Theodore as well. You know, the data has been showing us that there is a decrease in incidence in HIV over the years. But this is no reason for us to become complacent. And, you know, we need to ensure that our response programs continue and that whilst our rates have been reducing, it is not at zero. People are still being infected with HIV. Thanks.